So we're back to session 2, which is quite an important topic. I welcome Dr. Rajeshwaran, my colleague, and of course, leading on lots of things, also the chair of the National Diversity Forum and running the London Obesity Clinic, talking on modern management of obesity and giving us some really interesting perspectives. And please feel free to ask questions through the chat box or save them for the end. Over to you, Raj. Thank you.
Thank you. Thank you, Dr. Thakur. So what I'm going to do is give you a snapshot of the modern management of obesity. So it's going to take you through diets to exercise to medications and surgery. So it's a whole lot. Because it's I've been used to giving talks in person, so I don't know how to make it interactive, but as Dr. Thakur was mentioning, please feel free to ask questions. So what's the solution of the obesity pandemic? The thing is, it's more topical these days because we know that those who were admitted in intensive care unit and those who succumbed to COVID-19, most of them had obesity or obesity-related medical problems like diabetes, type 2 diabetes, and hypertension. So it's very important to understand about obesity. And I think it should be part and parcel of our training and even management, acute management within the hospital. Obesity is a chronic disease. So you got 3 or 4 options here. So what's the solution? Do you tell your patients to eat less, exercise more, or tell them, okay, go and eat less and exercise more, or is it something else? Obviously, because of this talk, you know that it can't be any of the top 3, so it must be the 4th one. If you tell your patients to go and eat less and exercise more, they're not going to come back to you the next time because everybody knows this. It's not rocket science. So there's a saying that obesity is not rocket science. In fact, it's much more complex than rocket science. So you need to have all the tips and tricks to tell your patients other than to eat less and exercise more. If you tell them go and eat cucumbers and lettuce and don't eat burgers and donuts, they're not going to come to you. They all know that. Everybody has got access to internet. You can just type anything and you come up with thousands of diets. So you shouldn't be saying that. You should be saying something different. So that's not the solution. The job for us is not to tell them what to do. The what to do is eating less and exercising more. You need to be finding out why is it they can't do. So why is it they do what they're doing now? And that is our job, to find out the why. And it's not the what. The what is old. It's a few decades old. I mean, they don't need to come to you as a doctor. They can go to a nutritionist or anyone who has lost weight. They can go to them and find out what diet they followed. But when they're coming to you, you need to be identifying why is it they're eating more despite the knowledge? And why is it that they can't exercise? And what's the reason for weight gain? So let's start with the definition of obesity. So as you can see over here, anything more than 30 is classified as obese. Class 3 obesity is more than 40. However, this varies from race, ethnicity. For example, for the South Asians, 27.5 and above is obesity. So even for the Chinese and Eastern Asian countries, it's 27.5, whereas the rest, it's 30 and above. But before I go on to the details of obesity classification, what I want to tell you is, people are very reluctant to come and see a doctor. They're very apprehensive. They usually come and say that, look, whenever I go for chest infection or a great toe nail infection. My doctor always tells me go and lose weight. So they get scared. So it's very important to have the right body language, the right words, and you need to be empathetic to your patients. Obesity is a chronic disease. For any chronic disease, the success is based on engagement. If your patients don't engage, they're going to fail. That's the case with any chronic disease like COPD, rheumatoid arthritis, asthma, type 2 diabetes. Patients need to keep coming back to healthcare professionals. And for that, you need to have the right attitude towards them. So we do not use the word obesity, fat, or big. The current classification is, you could say, okay, you've got an elevated body mass index, or you could say, if you're writing down notes, it's always good to say people with obesity. You can't say it's an obese person. You need to say people with obesity, and that's the nomenclature accepted in the medical profession. So please be empathetic to your patients and don't use the blame game approach. So the trend of obesity is increasing worldwide and it's relentless. So the last 20, 30 years, there are millions of diets: low carb, high protein, high fat, water diet, soup diet, cabbage diet, South Beach diet, all sort of nonsense diets, intermittent fasting. But the problem is, despite all these diets, the weight is going up and up, both in the UK, a lot of European countries, more so in the United States and Canada. So what it is clearly telling us is that these diets don't work. And even if they work, they may work for 6 months or a year. And people go back and put back the weight and put back much more than they have lost. And that's how it is usually. So there's a relentless increase in obesity. And why are we concerned? Because higher the obesity, the mortality is more. You can clearly see it's both for men and women. So the prevalence of obesity in the UK is same. It's exactly similar for men and women. However, it's the women who seek more help. We see in any clinics, both in primary care and in secondary care, the number of women seeking help is, in my clinic, and especially the obesity clinic, 90% of women, 10% of men. Though the prevalence in the country is same. Why is that? That's because women want to seek help, obviously because they're concerned with body image. Men are reluctant. So they're okay, and they would come to you only when they have a serious medical problem. So it's very important to ensure both men and women engage, and you give them what they want. That's the most important thing, is you need to find out what's their motivation. Why do they want to lose weight? So people don't come to a specialist obesity clinic saying that, look, I want to reduce my BMI because I want to get my diabetes better. They usually would come to you to say that, look, I need to feel more confident, my self-esteem is low, or I'm going for the summer holiday, I need to wear a bikini. That's the sort of standard thing. And then the next level is, they would say that, look, I'm not able to walk, or my surgeon says I have to lose weight, only then he's going to give me a new knee. And that's the second bit. So very few people come and say that, look, I need to lose weight to improve my health. In the last 6 months, I'm actually seeing the third category. Lots of people are coming to seek help, saying that, look, I've had enough. I'm scared with this COVID pandemic. I need to improve my health. So people are starting to move from body image issues towards health. And they're starting to realize these fat diets on daily meal don't work for too long, and they are starting to seek help. So soon you'll find the next few years, we as doctors will be inundated with patients asking for help. And that's when you need to tell them something different. Don't tell them to go and follow a diet, and that's not going to be useful. So as I said, obesity is complex, and it's very difficult for me in this 30 minutes to elaborate every reason for obesity. All I can tell you is adipose tissue is the main organ, the most important endocrine organ. Until recently, we thought that adipose tissue was an inert fat tissue, a lump of lard, and that's it. But now we know it's so complex and it plays a major role in satiety and fullness. Similarly, the pancreas, gut, genetics, and medication. So there are lots of reasons. So the reason I put the brain in the center is because 90% of the genes controlling metabolism is over there. over there. But the thing is, most of our focus in weight management is towards the tummy. And very few people look at the brain. So that's what we do is we do something different. So we focus on hunger. So we don't focus on the portion size or the snacking. Everybody knows all what to do. So we focus on and find out why is this person eating, what's making them hungry, and what type of hunger do they have. And that's what we do. So that's another MCQ. Obesity can lead to heart attack, cancer, stroke, blindness, or is it all of the above? In fact, it is all of the above because we clearly know it causes heart attack and stroke, but now we know that it also causes blindness. There are two mechanisms. Either it can cause blindness through macular degeneration or through raised intracranial pressure. So they have raised intracranial pressure leading to optic atrophy and blindness. And cancer is very common in people who are obese. So there are lots of cancers. The common cancers which we encounter is uterus, breast, ovary, large bowel, very common. And it's more so in Yorkshire. So the reason is people who are obese they're hyperinsulinemic and they have something called more of IGF, insulin-like growth factor, which stimulates growth. So obesity itself is a driver for growth. So cancer is more common. So very important to address these issues. When my patient comes to me, I explain to them that yes, we're going to help you lose weight, but what you need to understand is by losing weight, you're reducing the risk of having lots of cardiovascular problems, cancers, cirrhosis of the liver, blindness. So obesity is a disease which affects every part of the body. So what's this? I don't think you can read this. So this is the Foresight report. It's nearly 10 years old. It's a report published by the public health along with a few researchers in the UK. And I found out that there are hundreds of reasons for weight gain or triggers for weight gain. But the problem is we just focus on two things, exercise and food. But what makes them do that? So these are small bits. Let me show you the next slide, which is just zoomed in version. No, I don't think I got that. But what this slide shows is, it's not, for example, if you live in a community or an estate, it depends upon where is the nearest takeaway. How are the roads? Is there a park near you? That dictates everything. Or if you're driving down from your work, how many McDonald's are there? Every bit of this matters. How's your sleep? Who lives with you? Who are your close friends? All these matter. So it's your environment, your house, your the immediate neighborhood. Everything matters. So you can't blame patients. People have control on certain things, but certain things they do not have control. So this is the sort of cartoon which tells you what medical problems they can get. I've already alluded to cancer, but as you can see, people can develop fatty liver, which is no more an innocent condition. that goes on to develop steatosis, steatohepatitis, non-alcoholic fatty liver disease, cirrhosis, and cancer liver. Similarly, people can have sleep apnea, worsening COPD, asthma, idiopathic intracranial hypertension, stroke, cataracts, as I said, macular degeneration, diabetes, dyslipidemia, hypertension, and then cancers, which I mentioned, lots of gynecological problems, including infertility, polycystic ovary disease, osteoarthritis, gout, phlebitis. So there's a whole range of medical conditions related to obesity. There is a Royal College of Physicians paper which showed that just 10% reduction in weight can have a significant impact on longevity, reduction in cancer, reduction in reversal of diabetes. So 5 to 10% reduction in weight can reduce the risk to diabetes, improve lipid profile, reduce blood pressure, improve severity of sleep apnea, and also significantly improve quality of life. So when a patient comes to us, the most important thing is not to talk about 5 stone weight loss or 10 stone weight loss. We need to just focus on 5% weight loss. There's lots of evidence to show that 5% weight loss can have a significant impact on someone's quality of life. So that's the starting point. So people have different phenotypes. The culprit is the visceral fat. So the white bit which you see is the visceral fat, which is surrounding the intestine lumen. So the black bit is the intestine. And then over here is the subcutaneous. So subcutaneous fat is not so metabolically active as the visceral fat. So this is why we ask our patients we measure waist circumference, which gives us a fair idea of the problems they're facing. So BMI, which is kilogram per square meter, is a good guide. It's not a fantastic guide. As you all know that a lot of rugby players have a high BMI, but they're not obese. Obesity is a percentage of fat tissue. So not all rugby players are obese, they're fit, and the BMI is high. So BMI is a crude measure. Waist circumference is something better because it gives you an idea of how much visceral fat is there. So whereas the NICE recommends that anyone above a body mass index of 35, I don't think you should do a waist circumference because you'll always get it wrong. The reason people get it wrong is when people start getting bigger and bigger, the tummy gets bigger, but after some time, gravity takes over. So it's not going to keep going horizontally. It's going to drop down. So there's going to be an error. So it's not advisable to do a waist circumference above a body mass index of 35. So what are I talked about the general reasons for weight gain, like your friends, your family, your surroundings, but let's go into the details. So there are lots of hormones, and the problem is the whole mechanism of digestion starts not after you eat and digest and food goes into your stomach, actually is much before that. As soon as you look at food, as soon as you smell food, the process of digestion starts. And then there's a talk between the gut and the brain. So they talk to each other. There's a production of glucagon-like peptides, CCK, PYY, ghrelin, and hundreds of different hormones. They start to talk to each other. So there are a group of hunger hormones, then there's a group of hormones which causes satiety or fullness. So for example, ghrelin is the hunger hormone, leptin is the fullness hormone. And then there's an imbalance, and that's when the problem with hunger is. And each of these, so as I said, adipose tissue is a very active organ and plays a major role in hunger and fullness. Similarly, the intestine is no more a long hollow pipe, and we thought that all it does is absorbs nutrition and pushes food, undigested food down. But that's not the case. It's an active endocrine organ. It also produces lots of hormones, including glucagon-like peptide. You must have heard the talk about exenatide. Exenatide is glucagon-like peptide, which is naturally produced by the body. It's produced by the K cells and the L cells in the intestine, but it lasts in the system only for 2 minutes and it gets denatured. That's why we give injections, so that it lasts for longer. So glucagon-like peptide helps, tells the brain to stop eating, it slows the peristaltic movement, it brings about a sense of fullness, in addition to telling the pancreas to produce more insulin. So I just want to impress on you that there's hundreds of different factors. So the final common pathway is weight gain. So a final common pathway is eating more. So, and before the process of eating more, there's so many other mechanisms going on. So there's hormone signaling. As I just mentioned, there's a group of hormones called orexogenic hormones, that is, which makes you eat. And then there's a group of hormones called anorectic hormones, which makes you feel full. And there are several organs involved, including the brain, adipose tissue, gut, and pancreas. Now I'm just going to slightly touch upon it. I don't want you to get too carried away because it's too complex. But all I want to tell you is, when a patient comes to you, please remember this slide. It's not as simple as telling them to eat less. There's so many stimulation to these receptors, upregulation of receptors, and then there is a cross-reactivity. That's why there's no single drug which can help you lose weight. And there was a drug called rimonabant, which is a cannabinoid agonist called rimonabant. And what it did was it helped you reduce appetite. And it was fantastic. But the thing is, a lot of people had suicidal tendencies, and some people jumped off the roof. So what I'm trying to tell you is, if you try to fiddle around with one area of the brain which controls weight, the other area starts to hyperfunction. It is complex. That's why we don't have a single good drug which can help manage obesity. And it's so complex. Again, this is the same slide trying to make it more simple. Let me give you an example. A lot of my patients come and tell me, when I'm hungry, I am more awake and I feel energetic. But as soon as I've had a big meal, I feel tired and I feel like going to sleep. So they come and ask me, what's the reason? So if I'm hungry, why should I be awake? So that's because we've been programmed as animals, we've been programmed. As soon as an animal is hungry, it's suddenly awake. The reticular activating system is switched on, it's awake so that it can go and fetch food. So in millions of years ago, when we are hungry, we started to forage the forest, get some food or kill some animals. But as soon as we have had enough, the body starts to shut down so that we take rest and our body starts to repair. So that's the explanation. When you eat a lot, your suddenly body shuts down. So can you see that it's so complex. Similarly, people who stop smoking, they put on a lot of weight when they stop smoking. And the reason is, smoking is a reflex. It's a hand-mouth reflex. As soon as you give up smoking, you still carry on. So there should be another replacement, which is food. And also, cigarettes increases the basal metabolic rate because of the chemicals in it and also the temperature. As soon as that goes, suddenly the BMR drops down. So weight gain, depends on not just the quantity of food, but also depends on the speed of eating, the taste of food, time of eating. For example, a lot of my patients who had COVID, they lost weight quickly in the first few weeks. That is when their taste sensation was impaired. And then when they got better, immediately they started to eat more, and whatever weight they had lost, they put it back on. So can you see that? So it's not just the quantity of food, it's the taste of food, the speed of eating, the time of eating. So any medical intervention, this is what we do is we look at and find out if there are volumeters. If someone tells me, doctor, I don't eat anything, which is very common, say, oh, I don't know why I'm putting on weight, I don't eat anything at all, then I put them into this category of grazers. So that means they don't perceive that they're eating. That's the problem. So I don't tell them that you're lying. I tell them that you're not perceiving that you're eating. So they are grazers. They don't sit down at a table and eat a meal. And then, as I said, speed of eating. So one of the tricks we use is a rule of 20-20-20, that is 20 seconds to pick up food, 20 seconds to chew, 20-second gap. So when they reduce the speed of eating, the gut and the brain have enough time to talk to each other, and you can't even eat half a plate. So that helps. There are 7 different types of hunger pattern, and that's what we do is we try and find out what hunger pattern they've got. Sleep, medications, altered hormones, blood glucose, all these affects hunger pattern. So as you can see how complex it is. And we try and find out why they eat. Most of the time we eat not because we don't sit in a table to eat because we need some energy. We sit because we like that food. It's tasty, the smell is good, and that's why we eat. Or it's our family function, or you want a reward, and these are the reasons. So we try and, as I said, we try and find out what hunger pattern they've got. Is a grazer, do they eat big volumes of food, or they're a sweet eater, or there's a group of people called night eaters. That is, they have a big meal, say at 7 o'clock in the evening, and then they have another meal or a sandwich or some cereal around 12 o'clock. So we try to analyze this group of patients, and we found out that that group of patients were insomnic. So actually, basically, they couldn't sleep, so they went and ate more carbohydrate, and then they fell asleep. So carbohydrate stimulates the serotonin pathway that makes you go to sleep. So this is why when you find that when you have lots of pasta or rice and then a few glasses of beer, you always feel a bit dopey. That's because the huge surge of carbs makes you go to sleep. So telling that group of patients go and eat less is not going to work. If you sort out the insomnia, then they quickly would lose weight. So that is the reason we need to find out why they are doing it rather than telling them what to do. Reactive hypoglycemia is another condition. When people eat, the blood sugar should go up. Whereas in this group of patients, blood sugar actually drops. So they feel more hungry. So they have a meal, and after 2 hours, they go and eat again. So when we found out that the blood sugar has really dropped down, and that's because there's a surge in insulin with a high GI food, high glycemic index food, and the blood sugar drops. So in that group of patients, we give them low GI food, or we give a tablet called Accumbens, which prevents reactive hypoglycemia. So that's a slide to tell you how important sleep is. Sleep contributes to nearly 1/3 to 30% to 35% of our life. And if that 1/3 of our life is disturbed, you end up having a lot of problems, including inflammation, leading to insulin resistance, to diabetes, or it affects the appetite regulation, leading to obesity. So sleep is very common. So in obesity medicine, we spend a lot of time on sleep hygiene. I'm not just talking about sleep apnea, it could be any degree of sleep distortion. Then you come on to microbiomes. I'm sure you must have heard of it. There's millions of, if you say weigh 70 kg, 2 kilograms is bacteria, microbiomes in your gut, and they contribute to your hunger pattern. The genetics of the microbiome contributes to what you like, what you dislike, your bowel pattern, and everything. So microbiomes plays a huge role. And when you have lots of high fat, high sugar diet, all these processed food, it kills the microbiomes, and then they have the then obesity is triggered. So having a healthy microbiome is useful because that helps a good gut-brain talk. And this is the slide to show that how these microbiomes over there in the gut has an impact on adipose tissue, brain, liver. So there are a lot of probiotics, prebiotics. They say that a lot of colored vegetables like pepper, cucumber, purple cabbage, all these help improve our gut bacteria. I talked about medications. So in our clinic, we try and find out what medication is the culprit. Sometimes, for example, glycoside for diabetes, that triggers weight gain. That drops your blood sugar, makes you eat more. So we switch them to something like GLP-1 or acarbose or DPP-4. So some drugs like beta blockers can stimulate weight gain. A lot of antidepressants, anticonvulsants, and antipsychotics. So rather than blaming your patient, looking at the culprit is more important. So Ashish, how long do I have?
Raj, I think you're good to go for another, 15 minutes if you like. Okay. I mean, yeah.
That's fine. That's fine. Yeah, I've got slides for 15 minutes. Yeah. Okay, so when patients come to my clinic, this is what we do. Just like you would take a history when someone comes to medical admissions unit, we would start from childhood because the programming is intrauterine. So we find out what happened to them, how the childhood was, did they have a happy childhood, was there some sexual abuse, or the parents got divorced, all that matters. The age they attained menarche, puberty, what was the family history, is there any members of the family who have obesity, the social history, personal history, and was there any, what we're trying to do is we are picking up life-changing events. And then we go on to weight loss history. The classic story I hear is, my mother took me to a dietitian, and actually I was not very big, but I went to Weight Watchers, Slimming World, and had this Cambridge diet. I lost a lot of weight, I put it back on, then I went on another diet, I lost weight, and every time they lose weight, they feel good, and then slowly weight creeps up, but the next time it's not as good, the outcomes are not good. So every time you lose weight, what you're doing is, you're pushing your basal metabolic rate down. Basal metabolic rate is the amount of calories your body needs. So you mess up your body, so subsequent diets don't work very well. So we go through a very intensive history, and then we ask about the perception. What do they perceive about themselves? What is it they want to achieve? Because we try and help our patients to first understand that they shouldn't feel guilty about themselves. Weight is a symptom of a problem. Weight is not the problem. So we try and say, okay, let's work together to find what the problem is and not get fixated with the number on the scale. So that's what we do, is try and find out the underlying problem and then try to focus that. And then we break down motivation into a lot of small bits and bobs. So it could be as simple as, okay, I want to go in an aircraft, I don't want to have an extended seat belt. So those sort of things, we try and break down the motivation. Then, as I mentioned, we look at their hunger pattern, glycemic excursion, and body image. And then we have a team who look at psychology, and then the physiotherapist will look at their mobility. We have a sleep study, and I look at their endocrine problems. So this is in nutshell. Basically, we don't go into more endocrine stuff to start with. It's just thyroid function test, liver function, Usenis, HbA1c. For men, we do testosterone, because it's, in men, I'm sure you know, those who are morbidly obese, they have low LH, and testosterone. That's called hypogonadotrophic hypogonadism. So that means the pituitary doesn't perceive that the testosterone is low. So when in morbidly obese men, what happens is the testicles don't function very well because it's warm, because it's between the thigh and the tummy. So the testicles don't function very well. So what we do is we give them few weeks of testo-gel and kickstart the testosterone production. When testosterone is low, this lean body mass is low, they feel tired and lethargic, and the metabolism is slowed down. So we kickstart the metabolism by giving them testosterone. And as soon as they lose weight, suddenly the scrotum is more prominent and it's not as warm, it's cooler than the body temperature, it starts to function on its own, and then we withdraw the testosterone. That's what we do. So if the patient looks Cushingoid, then we would do a 24-hour cortisol. If Epworth score, that's a sleep study, if that is high, we would do a sleep study. So I'm just putting this slide up to show how complex it is, and a lot of stuff happens in the nucleus accumbens. So nucleus accumbens is the area of the brain which gives you a buzz. So when you go to a restaurant and you wait for the, say, pizza to come, the time of waiting, that's the real buzz. The real buzz is the waiting. As soon as you start eating the pizza, the buzz has gone. And then you switch on to something different. So the waiting game is the main area. And that's what we are all for. Those who are in clinical practice in obesity and researchers, we are focusing on the nucleus accumbens. And that's the same with the digital world. You know, in social media, when you send a message, you're waiting for the person to reply back. There's a ... coming. Someone is typing and you're waiting. And that's when the buzz is, the waiting game. So in obesity medicine, we're starting to look at this waiting game. And that is the nucleus accumbens. So treatment options, obviously there are lots of treatment options. In the end, there's gastric bypass. Before that, gastric band. In the UK, we are starting to reduce the usage of gastric band because it's not very effective. Pharmacotherapy, orlistat is a drug which is used, which prevents absorption of fat, but people have become too smart. It's been used for more than 10 years. So now when I prescribe orlistat, I tell them the side effects, that it can cause diarrhea, rectal incontinence, we should avoid fatty food. They stop fatty food completely and they move towards high carbohydrate. So they don't have side effects, but they put on weight. So that is one drug. And the next drug which we have started to use is Saxenda. Saxenda is a GLP, just like Victoza, liraglutide, but at a bigger dose. It's approved by NICE, especially in people above a body mass index of 35. So if anyone wants to know more about obesity, I would recommend that you look at this paper. It's in public domain. Even though it's 2017, it's a fantastic paper, and it gives you everything about obesity, mechanisms, pathophysiology, and management of obesity. And you can Google it and you'll get the full text. So as I said, these are the medications. Topiramate is like the drug for epilepsy, is licensed in the US for obesity. It's still not licensed in the UK. Mysimba, it again acts on the, just like bupropion for cigarettes, to prevent cigarette smoking. Mysimba use, but I haven't found any good outcomes in my patient. In fact, there are a lot of side effects, so I don't use that. The main drugs I use is orlistat and Saxenda. So these are the current interventions: surgical band, gastrectomy, where they take out 75% of the stomach. This is gastric bypass. Balloon is not so effective. You just put a balloon into the stomach, inflate it, leave it for 6 months and take it out again. So this is Brazilian patch, where they stitch it to the tongue and patient cannot turn the tongue around, so they lose weight, and then as soon as the patch is taken out, they put back the weight on. So what I'm trying to go and show you is lots of pictures from now on for the next 5 minutes to tell you how desperate we are. Oh, sorry. So this is a pill which is now licensed to be used. Hopefully it will come at the end of this year. They're small pebbles, very, very tiny globules. As soon as you swallow and drink water, it swells up and fills your tummy. It's called Genesis 100.
Is it like a bubble tea version?
Yeah, yeah. It's like a balloon version, but they're tiny globules, very microscopic globules. And as soon as you drink water, it swells, immediately swells up and fills your tummy. This is the one we used in Leeds for a short time. We wired the jaw, but the problem is they didn't lose weight because they are sipping Mars bars. So they were sipping melted Mars bars and milkshakes. So none of them lost weight. All they had was caries tooth. So when they ended up with a dentist. This is a gastric band. As you can see, the band is around the top of the stomach, and there's a port underneath the skin. So as I said, in the UK, we haven't found it very effective. So this is another one called Endo Barrier. It's a long tube which lines the intestine. It's inserted through an endoscope. It's like a huge condom, but it's open on both ends. And all it does is when you eat food, because it's lining the intestine, food doesn't get absorbed. Currently, it's gone back to research because there's some problem with biliary explant that was trying to take it out. There were some problems, and there was biliary sepsis, so it's gone back. So there's a center in Birmingham where you're using it. So this is the vest. So rather than cutting the stomach, what they thought was, oh, let's just use a vest which covers the stomach and presses it so the stomach cannot swell. So you start to feel full. This is called the FullSense device. So there's no surgery, it's a reversible procedure. There's a mesh which actually constricts the lower end of esophagus. This is called VBlock, the vagal nerve block. There's a pacemaker, and there are two leads on the vagus nerve on either sides. All they do is intermittently stimulate the vagus. Vagus controls appetite. So intermittent stimulation prevents adaptation. You know, in gastric band, they found out it fails after a few months is because the vagus is pressed for a longer time and it adapts. Whereas in this VBlock, vagal nerve block, there's intermittent stimulation of the vagus. So again, it's not used widely in real life. This is the one I was involved in. It's called Ability. Again, it's a Medtronic pacemaker. One lead sits on the greater curvature, other in the lesser curvature. But the thing is, I have the remote for the patient, and I dictate what time my patient eats, say from 10:25 to 10:30. And after that, he cannot eat. If he eats, he has severe stomach pain. So the stomach starts to contract. So I can dictate. And also, because it's got an accelerometer, if this patient gets up in the middle of the night, I know that he's got up, he's gone to the fridge, so I can pick that up. But because it sits close to the diaphragm, if this patient has got an apneic episode, even that can be picked up. So it's a fantastic equipment, but still is in research stages. This is now licensed to be used. All it is a PEG tube in the stomach, and there's a small motor. As soon as you had a big, say, a buffet meal, you go to the toilet, put some tap water, pump it in, and suck it out. That's it. So pump, and then you suck out the food, then you can go back for the second helping of your buffet. So this is called Aspire Assist. It's approved by FDA. So everyone, a lot of people come and tell me, okay, you're actually promoting bulimia. Well, yeah, it may be promoting bulimia, but what would you do for someone with a body mass index of, say, 110, who is not fit for anesthesia, is lying in the bed, you can't do anything, not fit for surgery. So these sort of equipments would help. So can you see this? This chap has just had a buffet. and he's come to the toilet. Now he's just pumping out everything. It's not very expensive. You can get it on eBay. I was joking. No, you can't get it on eBay. So this is one of my papers on surgical devices. Again, this is full text. You'll get it on, if you put it on Google with my name, you can read all about bariatric surgery and surgical devices.
So there's a comment, Raj, that this seems like swapping one eating disorder for another.
Yeah, absolutely. But the thing is, if someone is going to die with a morbidly, they're morbidly obese, you can't do anything. This is the last ditch attempt to save them. Yes, absolutely, I agree that we are moving them to one problem to another, but they are in the dead end, they're in a terminal illness. So that is why it's licensed by FDA. So I'm going to stop over here, and I think the summary of the whole talk would be, please do not be judgmental, be empathetic to your patients, use your proper body language, be inviting, and try to find out the why rather than the what. Give them some chance, and you will find that you already, as doctors, you do very well. But if you can just think about these points, definitely you could help your patient, because it costs our country 50 billion pounds. So it is an expensive disease. Okay, I'll stop here, Ashish.
Thanks, Raj. Thank you very much. That was really, really fascinating. I think a very, very wonderful overview. So does anyone have any question? Any question at all? Very comprehensive talk. It was really fascinating to see those pictures, interventions, and how the mindset needs to be tackled than the actual weight itself, isn't it? Is that what?
Yeah, someone has asked about semaglutide. So semaglutide is licensed for weight reduction currently in people with type 2 diabetes, but it's still not been approved for obesity without diabetes. Yes, slowly we will start to use semaglutide. Semaglutide is a long-acting GLP. Liraglutide is every day, whereas semaglutide is once a week, and we are going to get semaglutide oral tablets as well.
So thanks. Wonderful. This talk should be available virtually for everyone to go through it again going forwards. Just to wrap up, I think in terms of obesity weight management services, are there any changes happening, especially in the light of the COVID-19 pandemic? Now that's come to light that that particular group is the most vulnerable, as you mentioned at the outset of your talk.
Yeah, so I think the Public Health England is trying to bring about a lot of tier 3 services. So the weight management service in NHS is classified into tier 1, 2, 3, 4. Tier 4 is surgery. Tier 3 is specialist weight management, where they see a consultant and a team of dietitians, psychologists, physiotherapists. And tier 2 and tier 1 is like Weight Watchers, Slimming World, and all those. So when people come to tier 3, they're assessed by a medical consultant and a multidisciplinary.
And is there a BMI cutoff for that tier 3?
Yeah, it depends upon the funding in that particular region, but usually it's 30 and above.
Really? Okay. Right. So that's quite liberal, I think.
Yeah, 30, but for surgery it's different. For surgery it is 35 with comorbidity.
Right. Well, that's great. So with that, perhaps we will come to the end of the session. Thank you so much for attending, everyone.